Welcome to Dementia Friendly Prince George's County, Maryland Northern Sector webinar series for caregivers. Today's topic is Once an Adult, Twice a Child, sponsored by Prince George's County Government and the Department of Family Services.
Good evening, everybody. It's a pleasure to be with you tonight. We have lots of information to cover and a pretty intense information to cover, but I'm hoping that by the end of this presentation, you will have learned some things about dementia and you will be a little bit able to better prepare for the future. Dominique, if you could go ahead and go to the next slide for me, please. There you go. So our goal today is going to be to have a difficult conversation, but one that I think is really critical to help you understand the journey of individuals that have Alzheimer's type dementia and to help prepare. Learning about this disease trajectory will help you prepare emotionally, environmentally, financially, and physically. Next slide, please. So let's do some basic education right now. So let's talk a little bit about what is dementia. Everybody uses this word, dementia, and yet I find that many people don't really understand what it means. Basically, it's a global term that means without mind. So it's very general, just like the word flower is very general. But it's a term that describes numerous conditions that affect memory, orientation, problem-solving ability, and independence. So just like there are many different kinds of flowers, roses and daffodils and daisies, there are many kinds of dementia. And we're going to start there at that basic level and review some of the different kinds of dementia to help you get a better understanding of how global this term really is. Some dementias are reversible and some are not. And by the way, not all old people develop dementia, but the older we get, the higher our risk factors are in developing one of the irreversible dementias. Next slide. So let's talk about some of the reversible dementias. There's a lot of things that can actually affect our memory. Some of the common conditions that affect memory that are reversible, these are things that can be treated and reversed, include the following. And I'm sure these will not all come as a surprise to you. We talk a lot about dehydration and poor nutrition. It's critical in helping us think and function independently. One of the top diagnoses we see in our residents and our clients when they come back from the hospital is dehydration in particular. Many people with dementia are not receiving the necessary signals to remind them to drink or to eat appropriately. And so we see very often that these individuals are dehydrated. Many of them have poor nutritional intake. Infection and illness is another really common one. You may have heard the term UTI, urinary tract infection. It is the #1 infection that we see in our older population, particularly women, and it is something that is very prevalent. If we did a urinalysis on many of the older folks that I have in my care, for example, we would find that a significant percentage have a urinary tract infection. But we can't go around testing everybody for this every day, all the time, and we certainly can't go around giving antibiotics on a regular basis because that comes with all sorts of other adverse effects. So the standard of care is that we would only test for this if somebody was having any kind of a negative symptom or showing some kind of a sign that there was a problem. The issue that we see with infections in our population, those individuals with dementias, is that they don't present like they do in younger people. Younger woman, for example, would get a urinary tract infection and she's going to have physical pain. She's going to have pain upon urinating. She's going to have to go to the bathroom much more frequently, that kind of thing. And our older folks, particularly those with dementia, often don't receive those signals. So we see different kinds of things. We see somebody who's a little more lethargic, somebody who's not eating as much, somebody who's more agitated and gets upset more easily. that kind of thing. And it's when we see these kinds of signs that we start to do some testing to see what might really be going on. The second kind of infection that we see a lot of is pneumonias, but not the kind of pneumonias that we think of that are viral that you get from other people. It's aspiration pneumonia. That's a pneumonia that you get when your swallowing is impaired. We see that in the later stages of the disease, and it causes our food to go into our lungs. We'll talk about that more a little bit later this evening. Medication interactions, you hear a lot about this on the news. It's a big problem in this country. We live in a country where drugs are always the answer. The problem is the more drugs we take, the more interactions they are. I'm sure everybody on this call can think of a time that they took a medication for something and had some kind of an adverse reaction, some kind of an adverse effect. For example, an antibiotic that gave you a rash, or an allergy medication that made you drowsy. Well, if you think about it, when you start combining all of these different drugs in your body, the medication interactions can absolutely have a significant impact on cognition. This becomes even more of an issue for somebody that already has a diagnosis like Alzheimer's disease, and then on top of that has these medication interactions. So that is also one of the first things we always look at when somebody's cognition changes, their behavior changes. Did we make any changes or adjustments to medication? Was anything added or taken away? Any of those things can really affect people's ability to think clearly. Fatigue and insomnia, I bet particularly in this COVID world, everybody out there has probably had some issues with insomnia and as a result with fatigue. The more people don't sleep, the more discombobulated we get, quite frankly. The less able we are to deal with the world, the more irritated we get. So having good sleep is really, really critical. Depression is another one. Many of our older adults have lots of losses, particularly when they're losing their own independence. Maybe they now have to attend a program that they didn't really want to go to on their own. Maybe they have to move into an assisted living or even a nursing home. We lose the ability to drive. Our friends die. Many, many losses, and that can certainly lead to a depression and a deep, deep sadness. These are all things, if we evaluate them, we then treat for them, we can make better. And so these are called reversible things that can cause dementia. Next slide, please. We're going to focus tonight on the irreversible dementias. These are the things that happen that we still don't really have lots of answers to. As you know, there's an incredible amount of research that goes on in the area of Alzheimer's disease. And we have a lot of theories about what causes this. We know there's genes involved, but we really don't have any concrete answers. I can't tell you how many times I'll read a study on something that we know now is a factor in causing Alzheimer's disease, and a month later I'll read another study that says, well, no, maybe not. That part's really frustrating when we're trying to understand this disease and prepare for it. But we have lots to learn still. But Alzheimer's disease is a fatal brain disorder in which the nerve cells of the brains degenerate and die for unknown reasons. And again, we do know some factors that affect that, but we really don't ultimately understand the cause of this disease yet. Vascular dementia is a little bit different. That's caused by multiple mini strokes, also known as TIAs, transient ischemic attacks. So you may have heard of somebody that has these mini strokes, and it presents differently than Alzheimer's disease. Alzheimer's disease is progressive and degenerative, which means it gets worse over time. And I usually, when I train my staff, draw a picture of a person and I kind of show that there's an ongoing downhill decline in somebody's functional level. Vascular dementia presents differently. When somebody has a stroke, they may lose a little bit of functioning, but then they plateau at that level. They have another mini stroke, they lose a little more functioning, and then they plateau at that level. So it's more of a stair-step decline, a little bit different than the presentation of Alzheimer's disease. And the decline may go for a period of time before you see any further change. Lewy body disease is a complicated form of an irreversible dementia, and it's called the triangular dementia because it has three components. It has a component of memory loss at the top of the triangle. It also has a Parkinsonian-like component, so movement becomes affected. People are falling more, bumping into things. And the third part of the triangle is psychosis. So this individual often is hallucinating and having delusions on top of it. So a bit more complicated, often a bit more faster progressing, but it's something that we are talking more about now and diagnosing more frequently. Parkinson's disease, everybody thinks of Parkinson's disease as the disease that makes you shake. But Parkinson's disease is also progressive and degenerative. In addition to affecting the control of muscle activities and causing tremors, about 60% of the individuals that have Parkinson's at some point may develop some psychosis, and about 80% of those individuals will develop a dementia. So there is very much a cognitive component to Parkinson's disease as it progresses. Creutzfeldt-Jakob, we don't talk about that a whole lot. It's probably one of the diseases we see diagnosed the least in the world, but it's a rare fatal brain disease that's caused by infection, kind of also known as the human variant of mad cow disease. I've had a couple of individuals that were diagnosed with this in my care, and it is very different than Alzheimer's because that person is able to perform functions that somebody with Alzheimer's may not. So for example, one of the gentlemen we had, he couldn't find his room. He was not able to perform self-care, but he could come into the office, go to the computer, find a radio station on the computer and turn that on. So he still had some higher level executive function, but he had cognitive decline in a lot of the basic areas of care. Very interesting and very different. Frontal temporal lobar, bear with me, degeneration or frontal temporal dementia is the kind of dementia where the brain damage occurs in the front part of the brain and it affects personality and behavior. It also is the kind of dementia where we often see increased aggressiveness because that part of the brain, it also controls aggression. So we see this often in younger people with dementia, and also I've seen it in my experience more in men. It also has the effect of producing and a difficulty in producing and comprehending language. So again, these are different kinds of irreversible dementias. They all do present a little bit differently. And this is one of the reasons why trying to follow up and get a diagnosis can be helpful. Because if you know a little bit more about what you're dealing with and what kind of an Alzheimer's type dementia it is, then you can better prepare for that. Next slide, please. So let's focus a little bit on Alzheimer's disease, which is the most common of the irreversible dementias. Last statistic I saw, about 60% of people that had irreversible dementias had Alzheimer's type dementia. As I mentioned, it's progressive and degenerative. That is why it is so important for you to understand more about the trajectory of this disease so that you can prepare ahead of time for what is to come. That's the difficult part of this discussion. None of us want to face the eventual decline of our loved ones. That is one of the hardest things to do. But what I have found over the years, and every time I've done this presentation, I've had many families come up to me and thank me for actually educating them about this disease so that they can start to think and watch and prepare in advance. Age is the biggest predictor of onset, so the older we get, the higher our risk of developing Alzheimer's type dementia. You know, statistically, if you're in your 60s, you have about a 1 in 20 chance of getting Alzheimer's disease. By the time you're 85, you have about a 1 in 50%, 1 in 2% chance of getting Alzheimer's. So the older you get, the higher the risk factor of developing Alzheimer's disease. As I mentioned a little earlier, the cause is really still unknown. There's a lot of different theories, and I'm sure some of you may remember some of them from the past, like the aluminum theory, where we had done a variety of different autopsies, and we found that people with Alzheimer's disease had higher levels of aluminum in their brain, and this was advertised all over the place, and we were told not to drink out of aluminum cans, and to get rid of our aluminum cooking pots. I don't know if you remember that, but that was many years ago. And then when we did more autopsies on people without Alzheimer's, we found that aluminum levels are often elevated in people that don't have Alzheimer's disease. So we're not really sure. We do know that certain illnesses will cause you to have a higher risk factor. We know that there's a link to diabetes, and there's certainly a link to cardiovascular disease. So we do know that other illnesses absolutely can be a risk factor to developing Alzheimer's. So managing those conditions becomes even more important. There is no treatment and there is no cure. Let me say that again. There is no treatment and there is no cure. Hopefully one day, hopefully in the day of I'm still alive, that would be an amazing thing. The treatments that we have are really to manage symptoms and behaviors, but we can't really treat the disease. Yes, there are a couple of drugs out there that slow the disease process down, or so they say. But if you look at the statistics behind drugs like Aricept and Namenda and Exelon, what we know is that we slow the disease down by maybe a few months. It really does not stop the disease, cure the disease. We make this diagnosis by exception. So those of you that have had your loved ones to the doctor already know this, but we go to the doctor, we say, you know, something is not right, I'm not remembering correctly, I'm having a hard time putting things together. And the first thing the doctor will typically do is take a history. Then they will also do things like, you know, find out what other problems you're having. They will check your blood levels. They will start doing some testing. And as we test for a variety of different conditions, we start ruling things out. No, you don't have a tumor. No, you don't have cancer. No, you don't have this. No, you don't have that. And then once we're finished, by exception, if everything pans out, but you're still having these cognitive problems, usually we'll do a cognitive test as well, then we say that you have Alzheimer's disease. The statistics show that we're getting very good at this diagnosis by exception. And the last study I read showed that about 90 to 95% of those diagnoses actually showed to be accurate when they then followed up with an autopsy of the brain after the person had died. So with all the testing that we are able to do now, we do a better job of diagnosing this disease, even though we can't definitively do that until somebody has passed away and we autopsy the brain. Next slide, please. So this is a picture of a normal brain. And I took this out of one of the Alzheimer's Association books because I think it's just a nice, simple diagram. But you can see the brain is plump and full. I always liken it to a nice ripe plum, very juicy, lots of fluid in there, and very ripe looking, but looks good. Well, let's look at the next slide, and you can see what an abnormal brain looks like. This is the brain of somebody that has Alzheimer's disease, more likened to a prune, not a plum. But you can see that it is not, it's got lots and lots of striations now. and it is not as ripe and firm as a regular brain was. Let's go to the next slides. These are some scans that I think actually speak very clearly for themselves. So this is a normal brain. These two slides are actually my favorite slides. This is a normal brain during a PET scan. A PET scan is one of the scans that they can do to assess and evaluate for Alzheimer's disease. But everything that is yellow and red in this scan is live brain tissue. Everything that is purple and blue is dead brain cells. Let's move to the brain of an abnormal or an Alzheimer's brain in the next slide. And you can see a drastic difference here. The live brain cells have really shrunk, and the brain cells that are no longer alive and functioning are very significant. You can see just by the slide, anybody that has this disease, of course, are going to have a very, very difficult time functioning because the majority of their brain is no longer able to interpret the signals that they're getting from the environment and to give instruction back to the body. Let's go to the next slide, please. So this is a very, and I also borrowed this from the Brain Injury Association, as you can see in the bottom. But what I like about this is if you look at this, it shows the different regions of the brain and what part of our functioning they control. This is really important because everybody that has Alzheimer's disease has a different trajectory. This disease is a journey and it is different for every person. And this is the reason why. Depending on where the brain damage occurs, depending on where the neurons in the brain die off, that is going to be where the areas of deficits first appear. So we talked about the frontal lobe a little bit earlier. That is initiating a task. That is problem solving a task. That is using judgment. That is inhibition of behavior. We're going to talk about that more because disinhibition is one of the things that happens frequently with people that have Alzheimer's disease. And it can lead to a lot of miscommunication and problems with behavior and interactions with other people. But self-monitoring, motor planning, personality, emotions, all of those things are controlled by the frontal lobe. So if brain damage occurs in the frontal lobe, those are the areas that are going to be problematic. And again, if you look at the other areas here, the cerebellum, that's where balance and coordination and skilled motor activity occur. So if brain cells die in the cerebellum, that individual is going to have a more difficult time walking, is going to be falling more often, bumping into things, that kind of thing. Next slide, please. So let's talk about Alzheimer's disease in regards to stages. There are a variety of models out there that have different levels of stages and also different number of stages. I like to use a very basic model of an early, a moderate, and an advanced stage of the disease. I think it gets very complex when you're breaking it down into 8 stages, etc. So we're going to keep it simple for today. This early stage of the disease usually lasts between 2 and 4 years. Oftentimes, these individuals have not been diagnosed yet and are still living independently in the community. You can take the slide, move to the next part of the slide, but I'll keep talking. So these are folks that just have periodic memory loss. So they might still be working, still tending to their household, still paying their bills, doing all of those things, but there are periodic lapses in memory that family and friends often notice and start to become suspicious on. So it might be that person driving to work that forgets where they're going and gets completely lost, even though they've driven that route for 20 years. It might be somebody like my mother-in-law, who was world-renowned for her pina coladas and had difficulty getting the mixer out, the blender out, and instead got out a cake mixer and then couldn't figure out why she wasn't able to get the blender cup under the cake mixer. Little things like that are the things that we first start to see, and they are periodic. So these are not things you may see all the time, but oftentimes we notice in either a spouse or in our parents when we go over to see them that there's just some things that they're doing that don't seem to make a lot of sense. The mail has been sitting outside for several days when that is not how mom and dad ever lived before. They were always very diligent about getting the mail in, paying their bills, etc. Or maybe that newspaper that they loved so dearly is sitting outside and hasn't been brought in for several days. That's the kind of thing that we see in these early stages. The other thing is that spontaneity and initiative are reduced, and the individual isolates themselves more and more. So maybe this was somebody that loved to go out for dinner and now finds reasons and excuses not to go. I think in a large part, this individual is certainly very aware that something is wrong and is frightened and is in denial maybe, but also doesn't want anybody else to know. Because we all know that if we have Alzheimer's disease and this disease progresses, we will probably not be able to remain independently in our homes. And I think that scares everybody. Initially, these folks may be diagnosed as something called mild cognitive impairment, MCI. This is a term that we've been talking about more and more over the years. Some people with mild cognitive impairment don't progress into Alzheimer's disease, but more often than not, they do over a period of time. Next slide, please. Here we go. So in these early stages, we also see mood and personality changes occur. There's more suspiciousness, anger, and covering behavior. Where did those glasses go? I had my glasses right here. You must have taken them, right? That kind of thing. Judgment also decompensates and bad decisions are made. That's that person that feels like they need to go to the grocery store and walks out of the house at 3 a.m. because in their mind's eye, there's somewhere they need to go, something they need to do, and they're not recognizing that it's the middle of the night, it's winter, and that is not safe. We also notice here that money management becomes more difficult, and this is also where we see that people are either overpaying their bills, so they're paying the same bills 2 and 3 times and have a massive credit, or they don't pay their bills and there's letters coming from the electric utility saying that we're going to shut off your electricity if you don't pay. Routine chores take longer and are often not done completely. This is, the person whose house was always kept completely immaculate. And now things are stacking up and getting dirty and just doesn't look like things are being taken care of like they usually have been. Changes can be noticeable in a person's self-care. So maybe clothing might be soiled or there's a body odor present. Or maybe every time you go over to see mom, you notice that she's wearing the same clothes. Or maybe not even just the same clothes, but maybe the clothes are not buttoned appropriately, or there's 2 or 3 layers of clothes on top of each other. And again, just not something you would ever have seen that individual do in the past. Next slide, please. So at this stage, the priorities certainly, first of all, are to get an evaluation. It is really important at this point in time to get that individual to the doctor and to try to get an evaluation. Now, this is where that gets a little bit tricky, right? If mom is still very independent and doesn't want you to get involved, and you take her to the doctor and she goes in, she is probably going to put on her game face and the doctor's going to say, everything is just fine. The other problem is that we have lots of privacy laws. The doctor is not going to be able to tell you necessarily what he or she finds is going on with mom, because mom has to actually give permission for that. So how do you get information to the doctor so that the doctor knows what kinds of things you are seeing? That's going to be really important. And remember, while the doctor may not be able to tell you what's going on with mom, that doesn't mean that you cannot give information to the doctor in advance. So what I always suggest to families is write out a note or an email or a letter, and either drop it off at the doctor's office, or nowadays we do a lot of emailing, but make sure that the office manager gets that into the doctor's hand before the appointment. And just let that physician know that you are the daughter or the son or the spouse, and that you've observed the following kinds of things, and that you have concerns, and that you wanted the doctor to be aware. And physicians will absolutely take that information and then incorporate that into the exam to see what's going on with that person. So that's, of course, the first thing to do. But this is also the time to gather important documents before the person has what we call a loss of capacity. What we really mean is becomes incompetent to make decisions for themselves. So if there are documents in place of this kind, knowing where they are is certainly the first step. But oftentimes, for the majority of us, these documents don't exist. Advanced directives, this country, we're getting better at it, but many people don't have an advanced directive. An advanced directive includes delegating who your medical power of attorney is, and it would include things like a living will. A living will is a document that discusses your wishes. Do you want to, if you come into a terminal situation, or you have an illness and you end up in an end stage condition like Alzheimer's disease, does that person know what they want or not want done to take care of them? That would be a living will. The medical power of attorney is really critical. Having that allows you to interact with the medical providers that are providing the care to your loved one. Now, in Maryland, we have a law that actually allows for a surrogate medical power of attorney. So if there isn't an advance directive, then by Maryland law, the spouse would be the first medical power of attorney. If there is no spouse, then adult children would be next. If there are no adult children, then a sibling. If there is no sibling, it could be another relative, it could be a friend, it could even end up being a neighbor. So there is a hierarchy. And that would take the place if a medical power of attorney was not in writing. The problem with that is that surrogates have limited decision-making ability. And for example, if the surrogate power of attorney are the children, and there are 5 children, then all 5 children have equal say in what happens to that individual. And as we all know, families can be messy, and children do not always agree what should happen to mom or dad. And so that can also get very ugly. So we strongly encourage everybody to get an advance directive and to legally execute who it is you want to be your authorized decision maker. The other thing is that sometimes people are separated, or they don't like their spouse, or that spouse is really clingy to me and I know would not make the best decision for me because my spouse doesn't want to lose me. So sometimes, even though we have a spouse or an adult child, that might not be the person we think will be able to do what we want done to the way that we want it. So again, thinking this through is really important. Having these discussions are really, really important. And you want to do this before somebody loses the ability to do so. Once somebody is diagnosed with Alzheimer's disease and is unable to make decisions at this level, you cannot put these legal documents in place anymore. You also cannot alter existing documents like this that were already executed when the person still had capacity. So this can get very, very tricky. So the time to do this is now in the earlier stages. And by the way, it's not even when we see symptoms of dementia. These are conversations we should all be having with our loved ones, even now, even without dementia, because it is the best gift you can give to your family. I will tell you, I just had a meeting with a family member the other day, and this is a granddaughter of one of my residents. And she is the medical power of attorney. She is 23 years old. She does not know what her grandmother wanted. And she literally sat in the office and cried because she was so terrified of making the wrong decision. It can be a tremendous burden to try to make decisions like this for somebody if you've never ever talked about what they would have wanted. That becomes even more so as this disease progresses. My apologies. So having these documents put in place when people are still able to have conversations is really, really important. There is something called the Conversation Project, and you can just Google it. And at the end of the presentation, I'll put the website is there. But they actually have documents to guide you on how to broach this conversation. This is not an easy thing to just talk about. Hey, mom came over tonight, wanted to talk about what you want to do if you get really sick. It's not a conversation you can easily have, but there are a lot of ways that you can broach that conversation. Or, for example, if a friend gets sick, that would be a good time to say, so and so is taking care of her husband and they're really struggling with certain things. We've never talked about this before. So that might be a way to introduce that. So, something to think about. The Conversation Project has wonderful guides for families on how to talk to each other. And there's also a guide for how to talk to somebody that has an Alzheimer's type dementia. The Durable Financial Power of Attorney is an absolutely critical document. We do not have a state law that will authorize somebody to be a financial power of attorney. So you actually have to have a legal document in place in order to have any kind of say or ability to get at somebody's funds. So, for example, if you need to start paying bills for your parent and you're not on their bank account, the bank is not just going to let you start taking money out of that account to pay for bills. You have to have a durable financial power of attorney that you get from an attorney that is executed by an attorney. Every state has a little bit of different rules, and different banks have different requirements. So it would be really important to go to the bank of the family member you're caring for and tell them the situation and find out what they would accept. I've heard of numerous instances where somebody had a financial power of attorney, but the bank would not accept it. And as you all know, care is very, very expensive. And so you may need to be able to access your loved one's finances. You may need to be able to pay their bills, including a bill maybe for assisted living or for a nursing home, which is thousands of dollars a month. And you need this document to do that. So the time is now. Don't wait until this disease progresses. The time is now. This is also the time to gather a medical list. Many of us, some of our parents, mine included, keep us arm's length about their medical condition and don't always tell us what medicines they're on or what their health problems are. They may bring some things up in conversation, but you may not know the details. Now is the time to really try to get a handle on that, because if you do become the decision maker, you may need that information to pass that on to the current care providers. So talking to your loved one about their wishes is really critical. Next slide, please. I'm going to have to speed up because we're already at 7:44. All right.
You have a question,
Okay.
and the question is, should you ever tell the person they have Alzheimer's and why they are having trouble adapting?
So I think that that depends on the person and it depends on where they are in the disease process. Certainly in the early stages of the disease, really it should be the physician that tells them that they have Alzheimer's disease. That really should come from the doctor and take the family out of it. But because Alzheimer's disease has memory problems and current recent memory is what goes the most, you may find that you have to remind the person. Everything I recommend people do with their loved ones depends on that person's reaction. So some folks do, they need those reminders, and how you do it and the relationship you have with your loved one really depends on how you handle that and manage that. But they need those reminders and they do quite well. Oh, that's right, I have that disease. If you remind that person and they get angry and hostile and yelling and there's a negative outcome to that, then we try to minimize how often we say that and maybe choose your words, right? Words are very powerful. So you might not say, Dad, don't you remember you have Alzheimer's disease? But oh, Dad, I know my memory is not really great either. I'm sure that's just maybe something you forgot. So you got to kind of gauge the reaction of the person and go with the relationship that you've had with that person in your life in regards to how often and what exactly you say to them. I hope that helps. And also the other thing is not all people in families have the same relationship. So there are some things, for example, that my brothers can have a conversation with my parents about that goes better than if I have them. There are some things that my parents accept better from me. So that's where we're kind of coming together as a family. If there are other people that can help with that and figuring out who is best at having certain conversations can be very, very important and very helpful. Now let's talk about the moderate stages of the disease. And I am going to push through these slides a little bit faster. You will get this slide presentation at the end, so you can take your time and go through it. And I am always happy to, if you want to contact me at any point with questions, I'm happy to help even at a later time. But this stage of the disease is the longest, 2 to 10 years, but I've got to tell you, I see it last even longer now that we live so long, right? Many of my residents live into their high 90s and even low hundreds now. So this stage can last even longer. All the more reason why we need to be preparing for how we manage this disease, particularly financially. This is where we start to see more profound memory loss affecting self-care. So this might be where you see somebody starting to have incontinence accidents, or they're just not groomed as well. Maybe their hair's not combed, face isn't washed in the morning, clothes are dirty, or that kind of thing. Short-term memory deteriorates first. Long-term memory stays intact longer. So you might be, really astounded because Dad can have a conversation about, what happened 20 years ago and be able to elaborate on the stories, but they can't tell you that they had lunch. If you say, Dad, what'd you have for lunch? I didn't eat. Right? So you see a lot of that kind of thing. So always remember, short-term memory deteriorates first, long-term memory stays intact longer. You may also notice this person beginning to make repetitive statements, or asking repetitive questions, telling you the same story over and over again, even though they might have told you a half an hour ago. This is also the stage that we start seeing that there's difficulty recognizing family and friends. This is one of the hardest things for families, is when your loved one doesn't really recognize who you are anymore. I run a support group, and just this week in our support group, we had a couple of wives on, and their husbands don't remember who they are anymore and that they're married. And that is a devastating, devastating thing. But this is something that we do start to see at the moderate stages. This is where we see a lot of that increased restlessness, particularly in the late afternoon. You may have heard of it. It's called sundowning. We used to think that that occurred when day became night, but what we believe now is that it really is a function of exhaustion. If you think back to that colorful slide of the brain scan and the one for somebody that has Alzheimer's disease and how little of the brain is actually functioning, that person has to fight all day long just to remember simple things or perform simple tasks. And by the end of the day, they're absolutely exhausted. And that's where we see a lot of times a restlessness or the I want to go home, I want to go home. And we actually think sometimes that wanting to go home isn't always a place, although it might be because people revert back in time. So it might be a childhood home. But sometimes I want to go home really is that person expressing that they just want to feel okay. They want to be whole. They want to be themselves again. And they can't really describe that they're not. And it's a sad, difficult thing. Word finding and object identification. You may say, Mom, hand me that cup. And mom doesn't know what you're talking about because she doesn't recognize the word for cup. But if you point at the cup and say, hand me that cup, she might be able to do it. So now we're going to suggest that you start adding gestures to the things that you're asking someone to do so that you'll help give them another clue. Next slide, please.
You have 2 questions.
Okay.
The first question is there some training you can take to care for your loved ones?
Yeah, there is some training. Now, again, with COVID, a lot has changed and we're just starting to get back into it. But the Alzheimer's Association actually has some wonderful training videos on their website that you can click on, and they'll help you in the area of bathing and all sorts of things like that. I also suggest, and I know North County has a support group just like we do in South County. I belong to the South County Action Team. But I will tell you some of the best learning you will do is from other caregivers that are going through it or have gone through it in a support group. I can't tell you how many times a family will talk about something they're dealing with, and there won't be people like me that'll answer the question. It'll be another family member that has gone through it and has come up with some incredibly creative ways to address that. So there's a variety of resources out there. There are training videos. YouTube is amazing. There's all sorts of training on there. And more now as we start to come back together again as people and in groups, that you'll find that some of those things will be available as well.
Your second question is, how should we respond when your loved ones continue to ask to visit family members who are already deceased?
Yes, that's a really good one. So again, that's tricky depending on how you think that person will respond. If they are still functional enough to kind of understand what you're saying, you can try saying, "Oh, Mom, didn't you know that he passed away?" Um, but if that is going to elicit, or if you've tried that and it elicits a negative response, then say something somewhat generic. Say, I miss him too. We'll have to figure out a way to go do that. But trying to orient somebody to reality that somebody they love has died, a wife who's looking for her husband, see that all the time, or somebody that's looking for their small children. Sometimes the best way to do that is just to go with the emotion. Yeah, are you missing him? Me too, and maybe tell a story about that person, or what is it you miss most about Uncle Sal, or whoever it might be. But just to go with that emotion because that person's feeling a loss of some kind, but reminding them that that person has died is not always a good idea and could really elicit a real strong grief. Nobody told me. What do you mean my mother died? Nobody told me. And so it really doesn't serve a purpose because instead of making somebody feel better, we've now elicited an even worse reaction. All right, next part of the slide. Thanks. I hope that helps. So here's where we start to see perceptual motor skills become more and more impaired, because remember now, as brain cells are dying off, they are not interpreting the environment. So people are starting to walk into things, trip more often, fall. It's not that the eyes are necessarily not seeing anymore. It's that the brain doesn't recognize what the eyes are seeing. So there might be something right in front of that person and they walk into it as opposed to walking around it, because the brain can no longer say, hey, move out of the way. It's not able to interpret anymore what the eyes are seeing. So that's one of the things that happens there. So this is again where falling is a big one. And as we all know, when older people fall, they often break bones, and that's devastating. So one of the things we're going to talk about in a minute is how do you get ready for that. This is also, I mentioned this a little while ago, asking to go home frequently, maybe when they're in their own home, because home might have been a place a long time ago. And usually what we do is we will say something to the effect of, I want to go home too, but I've got to finish a few things. Let me do that, and I will make sure that you get home. So it might be something like that. Or I'll say, you know what? If you help me fold these clothes and get them engaged in the task, then we'll be able to go home a little bit sooner. That behavior usually fades as the evening goes on. It's usually something we see very often during the sundowning phase, between about 4 o'clock in the afternoon and 7 or 8 at night. So it tends to kind of slow down as the evening progresses. But if you can redirect that person into an activity, they will tend to do much, much better. I never say to them, this is your home, because in their mind's eye, it is not. And again, that can create a negative reaction. So instead, redirect them, right? Reassure them that they'll get home, and then redirect them into an activity, and over a little bit of time that should dissipate. So you're going to see a lot more of that in this stage. I want to talk about disinhibition a little bit, because that's the loss of impulse control. So this is that person that curses you out. And I always have to smile when a family says to me, what do you mean my mother called you a name? She would never curse. And I have to smile, because you're right. Mom, who was in control of her brain, may not have ever cursed at somebody. But mom with Alzheimer's disease, when the brain is no longer able to control those things we learn in our society are not appropriate, she's gonna think it and she's gonna say it. And she may think it and she may do it. So when somebody's disinhibited, we may see, for example, a man reach out and grab one of the caregivers by the breast, right? He's got a thought in his mind, he acts on it. He's not able to control that. Or we might see somebody sitting at the table and reaching into somebody else's plate to take their food. So they may see something they want, and they will pick it up and they will take it. And it's because they can't control that impulse anymore. And by the way, there is no yours and mine, it's all mine. Okay, so if you have a glass sitting there and I'm thirsty and I see that cup, I may pick it up and drink from it, because whatever I see and I want, I'm going to take. So there's that part. We talked a little bit about a person reverting back in time, thinking their children are small and their parents are still alive. Again, the same thing, redirecting them is not necessarily going to be helpful. So we always, reassure. I think your kids are with so-and-so, or I think Aunt Jane is taking care of the kids, but, I can go check on them if you want. But do what you can to reassure the person, and then redirect them into a different topic or a different activity or something to help with that. And then overstimulation. This is one I end up talking to families a lot about, particularly around holidays, right? So we have Easter coming. Do you take mom to the Easter party where we're going to have 25 family members? may not go so well. That might just be way more than she can handle at this point of the disease, and she may get overstimulated, and that's where you might see some of those restless behaviors, or somebody really just getting agitated. They can't handle the noises, the number of stimuli that are coming from all the people that are there. So it might not make sense to do that anymore, but instead maybe have a small gathering that you take mom to. It may not be the big Easter gathering, but maybe you come and you take mom out to lunch or something like that. All right, next slide, please. So here's the priorities at this stage. This is where you need to look at your environment. This is the person, remember, that's going to walk out at 3 o'clock in the morning because they decided they needed to go to work. So your door locks and your alarms are really, really important, making sure that they can't get out unattended if that is no longer safe for them. There's lots of different locks and alarms out there. What we do not recommend is that you put a double deadbolt on the door unless you have a key somewhere that is easily accessible in case of a fire or something, if there is an emergency. And we had a very, very sad, unfortunate case in Prince George's County. It's been a few years now, where somebody had a deadbolt lock on the door, and there was a fire and they couldn't get out. And they found the body stacked behind the door. They could not get out. So you don't want to do something like that. But there are all sorts of alarms that you can put on where if mom opens the door, an alarm goes off and you can hear it, things like that. There are locks that have combinations, so you don't need a key. So anybody that knows the combination could punch it in. Those are the kind of things to think about. But wandering is a big, big concern for somebody at this stage, and it's something we don't want to have to experience before we do this. Grab bars on toilets, transfer rails on beds. We talked about falls, right? So you want to safety-proof the environment. Those throw rugs, gotta go. The #1 trip hazard. So get rid of the throw rugs. You can put a rug down, but make it wall to wall. Put grab bars, and you can buy really inexpensive grab bars for a toilet. You don't have to pay to mount one in a wall. But you can buy them online that they just hook to the back of the toilet seat, but they can make a big difference in helping someone go from sitting to standing safely. Medications, mom and dad might not be wise for them just to be taking their own pills at this time. You've seen the little plastic pill dispensers that might work in the earlier stages. They even make fancy ones now. They're electronic. So Philips makes one, for example, that will at 1 o'clock dispense the pills you need, and it tells you your 1 o'clock medication is ready for you, and it will remind you to take your pills. So there's all different kinds of pill dispensers, but that might be a really important thing because medication mismanagement is very, very common in people that have Alzheimer's type dementia, taking too many of the same pill, not taking important medicines, etc. So thinking about that at this point is real critical. And then technology, we live in a wonderful world of technology. You can buy a camera to put in mom's house for $250 that doesn't require anything but a plug into the wall and a little bit of internet if you're worried about mom at night and you don't have anyone there with her. So there are ways now, there's wearable GPS watches, there's GPS inserts that you can put into someone's shoes. So if somebody doesn't wear a watch or they don't carry a cell phone, because you have that on your cell phone, there's inserts for shoes, but there's all sorts of different GPSs for somebody that might inadvertently wander. This is also the stage to consider some support services. If mom is alone all day long and you have to go to work, then maybe sending her to an adult day program a couple days a week or every day even, whatever, can be really helpful. Or getting some home caring, getting an aide in that can be there for certain hours of the day. So this is the time to start exploring that. And I always recommend you explore before you need. because then you're not dealing with a crisis. When you're dealing with a crisis, then you're going to find that you have less options, because you're going to have to move mom to whatever assisted living has an available bed, for example, as opposed to somebody that shops around ahead of time, may not have any need or intent to move mom, but you've looked at the facilities in the area, you know what their costs are, you figured out which one feels most comfortable. That's the time to do this now, not when you need to place someone on an emergency basis. So those are the priorities that you want to focus on now. Now let's talk about the late stages of Alzheimer's disease. This is truly when people have lost most of their ability for self-care. At this point, that person is not able to bathe themselves, to toilet themselves, they're incontinent, and at some point not even able to feed themselves. Communication is significantly impaired, so this person may not be talking anymore. That's a natural part of this disease progression. They may respond yes or no. You might be able to get a smile, you might get a tear, but you're not going to be able to have an exchange. And that can be a hard one for families. I see it when they come to visit mom. So I always encourage them to come with something to do. Bring the newspaper and read to mom, bring a photo album, because you're going to be having the conversation with that individual. They're often not going to be able to have it back with you. This individual is not recognizing most of their family often. They may recognize that they know you, but they, instead of calling you their daughter, they might call you their grandmother or their aunt. They might get you confused with somebody else. And also remember that word finding becomes an issue, so they may just confuse some of the words. But you may come to visit, or you may see your loved one, and they really don't always know who you are. It's very, very difficult. Infections at this point are much more prevalent. Remember, at this point, that person is incontinent, so no matter how often you toilet them, they are going to be spending time sitting probably in a wet Depends or even a soil Depends. And so the potential for infections is much, much higher and much more recurrent. We're also not walking as much anymore. We're not drinking enough. So all of those factors combined will cause us to have these repeat infections. All ADLs, activities of daily living, must be performed by others. That means the feeding, that means the bathing, that means the dressing, that means the toileting. So the activities of daily living must be performed by others. And the IADLs, things like cooking and cleaning, that already has been happening by somebody else for a longer period of time. Here we're starting to worry about secondary problems, such as swallowing issues. Again, swallowing is one of the functions controlled by the brain. It's involuntary, but as the brain becomes more damaged, even swallowing becomes an issue. And that aspiration pneumonia that I talked about earlier in the presentation now becomes more of an issue. This person might need you to modify their food, so it may no longer be regular, but you might have to chop it up. You might have to puree it to a pudding consistency. You might have to thicken liquids, but you're always looking for things when somebody's eating, like coughing, drooling, pocketing of food. Those are kind of the signs that this person may be aspirating, and it may be time to kind of change the type of food that they're eating. This individual is also starting to sleep much more, many more hours of the day and night. That is normal. That is the body's way of protecting itself. So this is a person that might sleep, nap frequently throughout the day, and only be awake for a few hours at a time. Next slide, please. So here the priorities really do change at this point, because that person is probably not walking or not walking well, right? So they need to be in a wheelchair, because otherwise they might fall. we are starting to look at secondary problems. So, for example, skin breakdown. If I'm no longer able to get up and move around and I'm sitting in the same spot for hours at a time, I have the potential of having skin breakdown and developing wounds. So it becomes really important to make sure that whatever the surface is somebody's sitting on, if it's a wheelchair, that they have a good cushion, if it's a recliner or if they're in bed, that they have the right kind of cushioning underneath them to help reduce the risk of skin breakdown. But the body has to move. You can't just leave somebody laying in one position for hours and days on end without skin breakdown starting to occur. So if you're caring for somebody at this stage, every time you change them, look at their skin. If it's turning red, that's a pressure point. At some point, if you don't do something about that, it's going to break down and become an open wound. Pillows become your best friend. And we have all sorts of adaptive devices. For example, the back of the heels. There's not a whole lot of fat there. And if somebody's laying on their back for hours on end, the back of the heel can blister and open up into a wound. There's all sorts of heel protectors that you can purchase now that will help float that heel. Or you can put a pillow behind the calves when that person's laying in bed so that those heels are elevated off of the bed and that pressure is removed. So learning that kind of thing is really important. If you've got a home health aide coming in, a nursing assistant, that individual is going to be able to show you how to do that. If your loved one's in a facility, they'll be able to show you how to do that. If your loved one attends a day program, there's going to be a nurse there that can teach you how to do that. And then we always have Dr. Google, right? You can Google anything. So teach yourself, get on YouTube, watch some videos, and also go and look for supportive devices. It's amazing even on Amazon what you can buy now to help with these kinds of things. They're widely available. There's also something called the Alzheimer's store. If you've never looked at that website, they have incredible gadgets on that website that are designed specifically for people with Alzheimer's. Well worth looking at. We talked about aspiration, modifying that food consistency, right? Really, really important. So if you notice that your loved one is starting to choke or to cough or to drool, then really kind of think about what is causing that. Watch. Is it when they're drinking? Are they eating too fast? Do they need their food chopped up more? But you can be a detective and try to figure that out and just try some different things. And if you really needed to, you could always get a dietitian, a consult with a dietitian, and have that dietitian do a swallowing evaluation to help guide you on what to do. Because even thickening liquids, that can be tricky because there's different thick. You can have nectar thickness, you can have honey consistency, you can have pudding consistency. And depending on what's happening with that person, a different thickness of the liquid might make the positive difference. But what we're trying to do is prevent the food and the drink from going into the lungs where it will cause a pneumonia. Eventually, somebody that lives to this stage of Alzheimer's disease, it is important for you to know that the most common cause of death is aspiration pneumonia. So the feeding piece is really important to monitor. UTIs, those urinary tract infections, again, changing somebody on a regular basis becomes really, really important because those UTIs, learning how to clean someone, cleaning a woman, for example, from front to back, not from back to front, really critical. Not something many people will think about, right? But it becomes important in preventing some of these urinary tract infections. Constipation can also be another problem. First of all, at this point, we might be taking multiple medications, including pain medicine. So if this person is taking pain medication, particularly things like morphine or Percocet, or is on a fentanyl patch or anything like that that's a narcotic, those are extremely constipating. So you're going to probably need to add a stool softener. It should be a standard of care, and unfortunately not. We don't always remember to do that, but when a provider prescribes a narcotic, they should also be prescribing a stool softener, because I can promise you constipation will be an issue. But the things that you're looking for now at this point in time in life are comfort. This is where we focus on comfort. We can't make this disease better, but by managing these secondary problems, by managing pain, we can make such a distinct difference in that person's quality of life. Things like music, even in the advanced stages, there's something in our brain. Music is just magical. Put on some music, but not your music. Music that dad listened to when he was younger, right? If he was a blues guy, put on some blues. If he was a country guy, put on some country, not modern country, but old country. And that's where putting an Alexa in somebody's room can be a wonderful thing. And you just tell Alexa to play some country music from the 70s, and it's amazing what you can do there. At this point in time, it would also be a good idea to have a conversation with the medical provider to talk about whether or not it's time for hospice. We wait too long in this country to bring hospice on board, and part of it is because none of us want to think that that might be where we are. But hospice is actually an amazing service, and they're there to help not just your loved one, but you as well, because you will be suffering as you're dealing with this, and you will be struggling. And they have social workers, and they have pastors and ministers and all sorts of individuals to help the families that are caring for someone that is dying or that is in the end stages of their life. And they are also the experts at some of these things we're talking about, preventing those secondary problems and the pain management. And they have access to things that you can't just immediately go out and get. Not always so easy. And there's 24-hour access. So if at 3 a.m. mom's not breathing so well, you've got a lifeline that you can call. So that is something to absolutely consider at this stage of the disease. Next slide, please. So just an overview on staying a step ahead. You understand a little bit more about the disease process now. I would encourage you to flip through these slides another time on your own, particularly focus on the area that you think your loved one might be in. See if that is where they are in the process, in this journey that they're on. And make sure that you've done those things that we talked about, right? Make sure you've got those important papers in place. Make sure you can access dad's bank account if you need to pay his bills. Some of that stuff is extremely complicated. And if you wait too long, particularly with the financial piece, you will end up having to apply for guardianship through the court system. And I will tell you now, if there are multiple families involved, and if there's any strife at all about the finances, then the courts will appoint an attorney to take over that part of dad's care, and you won't have any say-so at all. So put those documents in place early on so that you can do what you need to do to take care of your loved one. Even if it's a spouse, right? Not all spouses have each other on all of their bank accounts. So it's something to think about, whether you're married and caring for a spouse, whether it's a parent or a sibling, another loved one, etc. Get that loved one's business in order. Advance directives, financial and medical powers of attorney. Know where those documents are kept. Make sure the physician or the primary care provider has those. There's lots of wonderful elder care attorneys out there that specialize in this. I would Google them for wherever it is you live and find somebody or talk to somebody and get a referral, but they can often help you put those documents in place so that they are actually legally appropriate for the state of Maryland. Here's the big one. This one sooner rather than later. Do a financial analysis. Care is expensive. Medicare does not pay for long-term care. I can't tell you how often people are in shock when I say that. Yes, if mom has a fall and goes to the hospital and she's there for 3 days, she can go into a nursing home for rehab. Medicare will pay for the first 20 days, 100%, but on day 21, you will be paying a pretty significant copay. I can't remember what it is exactly right now, but I want to say it's like $162 a day for 80 more days. After day 100, you're paying for it all out of pocket. Remember, we said that this disease trajectory is 20, maybe 30 years. That's an incredible amount of money. 1 month, and let's talk about assisted living. 1 month in an assisted living can range anywhere, and you're lucky if you find a place for $4,000, $4,500 to $7,000 or $8,000 a month. Even somebody who has a home to sell and has money in savings is going to probably run out of funds at some point. And then you will be in a whole nother world of applying for Medicaid, aid to the poor. So Medicare is health care for seniors. So every senior that is 65 or older that worked a certain number of years is eligible for Medicare. But just like private health insurance, Medicare covers things like doctor's appointments, maybe medications if you get the whole, the Part D plan, hospitalizations to a certain extent. That's what Medicare covers. Medicare does not cover adult medical daycare, assisted living, nursing home care. And many families don't realize that. So please understand. And Blue Cross does not cover this. Aetna does not cover this. United Healthcare does not cover this. So health insurance does not cover long-term care. So planning ahead financially is one of the most critical things you need to do so that you don't run out of funds for your loved one. Explore the care options that are available before you need them. We talked about that. Medical daycare allows mom to stay home, a lot less expensive. Many people start in the medical day program and may attend that day program for numerous years. Costs money, but it's a lot less expensive. An average medical day program in Maryland costs, I would say, on average about $100 a day. A little bit less, a little bit more maybe if transportation's included, but they will come to your house. They will pick mom up. They will take her to the center. They will feed her. They will do activities. There's a nurse there. So you're getting lots of service for mom, and then they take her back home again in the evening. So that is a lower cost alternative. Then you have home care. Home care can really range in cost, but a nursing assistant may cost as much as $25, $28 an hour. So again, can be very expensive. So explore those options in advance before you need them. Next slide, please. I think we're just about done now. I'm sorry, I've really gone over. So here's a couple of resources. There's something called Maryland Access Point, and each county has a phone number you can call. And you can call there and you can tell them what your situation is and what it is you need, and they will tell you what resources are available. There's always the Alzheimer's Association as well. So you've got wonderful resources here in Maryland that will help you. The Department on Aging, they are part of this Maryland Access Point, and they have lists. They can tell you all sorts of services that are available to you to help you care for your loved one. Next slide. And then these are a couple of other for the advanced directives. I definitely encourage you all to look up the Conversation Project. It's a wonderful service, and they will give you great guidance on how to speak to your loved one. The Maryland Attorney General, they have free advanced directives that you can actually just download and print, and that you can fill out with your loved one, no attorney required. You will need a witness, and it has to be a witness that has no financial gain from the situation. So that's an option. 5 Wishes is also something I would recommend you look at. It's a document that has numerous questions in layman's terms about what kinds of things your loved one wants for themselves. If I get really sick, do I want you to put a tube down my throat? If I get really sick, do I want a feeding tube? These are some hard, difficult things, but 5 Wishes makes that very easy to understand, and it's a form that can be filled out and then taken to a physician. The second thing on here, marylandmolst.org. I could do a 2-hour presentation just on that, but that is a state form that actually is really critical if somebody has a do not resuscitate order in place, because if you call an ambulance to your house and that form doesn't exist, even if there is an advance directive, they may still do CPR. So that Maryland Wolf's form is something that your physician, your mom, your father, your husband, whoever the physician is for your loved one, can fill out for them, that you would keep at home. We suggest putting it on a refrigerator or somewhere where if you ever have to call 911, it's very handy. Take a picture of it in your phone. So if you're out at a restaurant and that exists, you have it with you if you don't have a paper copy. But that marylandmolst.org is the website, the official state website. There's a consumer guide on there that talks you through the form. But please know that that form must be filled out by a healthcare provider. You cannot fill that out. So it has to be signed by a physician, a nurse practitioner, or a physician's assistant. But those are some resources on advanced directives. And for all of you out there, I would recommend, if you haven't done that yet, and consider doing it for yourselves. The best gift you can give to your family members, because remember, we're not all guaranteed a long life. Anything can happen to any of us at any point in time. So those are some resources for you there. Next slide. I think that might be the end of my presentation.